Thank you for having me all the way from Australia. I'm going to speak about 3 areas. The first one is the trends in Australia and what we're doing to address 2 key issues, which Nisha and I were surprisingly talking about before this. Why is trans always identified as an at-risk population? So one of the things that's really important for me is, as a worker representing the trans community in Australia, is what are we doing to minimise that, to stop it from being the at-risk community? So those prevention strategies. And the second arm is, of course, what are we doing with our HIV prevention, because it is still considered an at-risk population. So the 3 things I'm going to speak about are trends in Australia. Sorry, I'm Australian, so speaking from experience. And then the early intervention strategies with families, because young people are the emergent population that we're seeing in Australia. And this is where prevention to stop an emerging to stop the population from becoming again an at-risk population. And the third one is a shift in mental health care to support social transition, again to minimise risk for harm and high-risk taking activities. So what has changed in Australia? There's been an increase in young people coming out and openly expressing their identity, much younger than we've seen historically. The interest, as I've been working at the Gender Centre for 13 years, it's 15. So I think I just cut and paste a really old bio when I sent Rena that. When I started 15 years ago, the average age I saw in our service was 25 to 35. The average age I'm seeing now is 13 to 15. So huge shift. And what we've seen in those 15 years I've been at the centre is an increase in government recognition of young people and trans legislation. And the example I use all the time is something that you can Google if you're interested, which is Legal Bulletin 55, which the Australian New South Wales State Government has written a public document that allows young people to come out in schools. And it lists all the supports and systems to ensure these young people stay engaged, connected, educated, but living authentically as who they are. So see, we've already got strategies to reduce our potential emerging at-risk population. So the next one, sorry, I think something went wrong in my email that I now have this wonderful, amazing slideshow. The problem with our emerging young people population is the supports they've needed have not kept up with the numbers presenting. And so mental health is one of our biggest issues. With mental health, we have young people engaging in high-risk activities, high-risk opportunities for homelessness, disengagement. So all the legislation in the world is wonderful, but if we do not have the systems in place to support young people as this is happening, then we have issues such as HIV and other STI risks. So what we've started to do is look at managing those psychosocial issues. And recent research says that this approach is the best way to prevent young people from engaging in risk-taking activities. So in 2017, a report called Trans Pathways was established. It was published, and it was a 12-month study across Australia where over 897 young people identifying as transgender and gender diverse between the ages of 14 and 25 did an online response about their mental health and well-being. So this is the data. I won't go through it because it's really long, but significantly the things that came out about it was just under 50% of the young people reported having attempted suicide. 79% report persistently self-harming. So we already have this high mental health. And sadly, 72% of the young people have formal diagnoses of depression and anxiety. We also saw things such as eating disorders, which were being addressed inappropriately as seen as anorexia nervosa, rather than a recognition of gender dysphoria and a mechanism for managing, avoiding the onset of puberty and secondary sex characteristics. It's a mechanism of controlling dysphoria versus an anorexia nervosa diagnosis. So all of these things are the issues that we face. So the strategies that we were looking at that were recommended was to create safe and supportive families, to allow and realise that children exploring their identities is okay, and to promote and enact trans-inclusive public policies, for example, access to gendered facilities. So a young trans boy can walk into a male toilet. Sometimes parents, and I admit, I run a parents group in Australia, and the funniest thing I hear is the parent telling the story of the first time their trans son or daughter walked into the toilet of their affirmed gender. And the parent stands there wringing their hands, waiting for the child to come out screaming. The child walks out and says, well, that's anticlimactic, and mum's in tears. So we see all of that. And of course, trans-inclusive legislation and data collection. And data collection is the big evidence-based practice that we need. It's really interesting that previous speakers mentioned that Thailand is seen as this wonderful utopia for trans people because it's inclusive and welcoming, but you don't have legislation. Welcome to Australia, we have legislation, but the community is not welcoming. We have all the laws, but we don't have a community that understands yet. So if we merge the two, we'll have utopia. Let's move somewhere else and put your acceptance of community and our laws, and we'll have a wonderful space. So that's one of the trends. Oh, sorry, it doesn't want to move forward. And the next one is that we've just seen a wonderful presentation on prescribing of hormones. The sad thing that we're seeing in Australia, because the WPATH standards of care talk about hormones. I have an emerging population of young people who see that pill as the solution to everything. So they don't address the psychosocial issues of transition. They don't understand or process their emotive journey and the understanding of who they are and what they are as a human being, as a male, as a female, as a person. And so what we're seeing is young people then going through their transition, taking their magic tablet, and then still experiencing significant dysphoria, which again, they go, oh, it didn't work. And they re-engage yet again in high-risk taking activities because they're not feeling authentic. So unfortunately, we have a me generation that wants the magic pill and to queue jump. If anyone's as old as me, I have a 40-year-old son, so I'm really old. They'll remember a long time ago, before WPATH, there used to be the Harry Benjamin standards of care, which said that you had to live authentically in social transition for a year before you could undertake medical transition. And while I don't agree with it from the informed consent model, I do agree there needs to be a balance because practitioners are prescribing the tablet, saying to young people, yes, this will help you, but young people are going, this will fix me. So what we're seeing as a trend in Australia is young people and even older people seeing this magic tablet and not addressing some of the issues that lead to engagement in risk-taking activities. So in relation to what does this mean for HIV, however, with risk-taking activities, a study was done, we heard someone speak from the Kirby Institute this morning, they're involved in this research. And it was looking at HIV and STI infection, and the three knowns that they introduced was that trans people were considered to be a high-risk community. The known rates overseas were higher. And in Australia, trans women had higher rates of STIs. And this was done in 2019. Interestingly enough, the finding says that this trans and cis populations, the trans population in Australia did not have the same high HIV infection and STI infection rates as other nations. So from that, we could extrapolate that we must be doing something right because we're not seeing that massive increase. So from that, what this means for frontline community workers, sorry, again, apologies, is for us, I work at the Gender Centre. We're a service that's existed for 36 years. We're the only service of its kind in the nation, and we're a team of 6 people. And my purview is to cover the state of New South Wales. We're a state-funded service. And to give you an idea of how big New South Wales is, we are 1.5 times the size of Thailand, and that's how far I travel. But that's just me. I'm one person in a team of 6. So to reach this, we started some partnerships, and that was the best way to do it. And someone beautifully said the best way to get a trans person in the door is offer them pills that will transition them, give them hormones. So we started our partnership with sexual health clinics because unfortunately in Australia, where we were talking about trans healthcare as primary healthcare, unfortunately in Australia we have legislation that says that prescribing of hormones must be initiated by a specialist. It can be maintained by a general practitioner, but it must be. And the outcry when that came out for people that live in rural, regional, and remote areas. So if you're looking at just the state of New South Wales, and there's 7 states, so we're only one space, and that's just 1.5 times the size of Thailand. Think of how far you would have to travel to come to a city centre to get healthcare. So the government reviewed and said, okay, sexual health clinics are all over the place. Let's allow sexual health doctors to also become prescribers. So we started some really significant partnerships with sexual health clinics. And the first one that we did was in a little place called Dubbo, which if anyone knows New South Wales, you get in a car, which I do regularly, and you drive 7.5 hours west of Sydney at 120 k's an hour. And that's how far it is to go to a country town. And our partnership is with a sexual health clinic out there. And we set it up with them that I provide frontline casework and psychology, and the clinic provides the rest. And the roles that we came up with for the sexual health clinic was sexual health care, because that's their funding. To prescribe, I don't know if you use the same language in Asia as we do in Australia, stage 2, which is cross-sex hormones, to transgender people. To deliver community social work and support. And that meant that the nurses stepped up and did casework, social work, support, family support. And we agreed in our partnership that they could ring us because distance. Telehealth is wonderful in Australia because of distance. So we became part of telehealth, so they can ring us if they get something that throws them a curveball, and then they can link in and ask us for support. And to provide safe spaces. The World Health Organization, HIV for Transgender Populations 2015, said very specifically to create safe spaces for at-risk populations. And this is one of them. And so for all of our partnerships, they received specialized training that was peer-led around trans healthcare. And so this model was effective in, as I said, we started in Dubbo as a small clinic. And here's my lovely little group of young people that live in the bush in Outback Australia. And so we started this project, and this will give you an idea of what it looks like. To keep this, the state health system funds me travelling and funds the clinic to deliver these services. It doesn't look like amazing numbers, but when you consider I'm in a small country town in Outback, New South Wales, a population of 50 trans people accessing hormones and STI, HIV healthcare is pretty huge. So in the course of 1 year, I made 4 trips out west. I saw 71 different trans people or families across those areas. If anyone wants to Google it, you'll see a massive map of that region. I travel approximately 3,000 kilometers in 4 days to see this population. And we deliver training in all of these areas to schools, to healthcare, to psychologists, anyone that wants training on the way. And then we run group meetings. So we peer-led social support, because isolation in rural and regional remote areas is significant for trans people. So we create focus spaces. Youth groups, young people need their own space. So we ran a youth group. We ran a youth camp, in fact. And the aim of the camp was great. We had 35 children come from across the state of New South Wales to a camp, and not one psychologist except me, because I was running it, was allowed. Not one cis person was allowed except me, because I had to sign off on it all. Every volunteer, every staff member, every participant was trans. And the aim of being at camp was to have fun. You weren't allowed to talk about being trans. You were allowed to talk about being you. And most parents were pushing their kids on the bus to come to the camp. Within 4 hours of arriving at the camp, the kids were going, when's the next one? Because I don't want to finish this one and have no hope. So the impact on finding their peers. So that's our little case study. The sexual health clinic, 50 people access the sexual health clinic. It only has 2 sexual health nurses and a visiting sexual health doctor. So the sexual health nurses became the primary area and point of contact. The doctor initiated. And the sexual health doctor put up their hand and said, yep, I'm happy to learn how to prescribe. As we've heard, it's not rocket science. But the sexual health nurses did all the blood work. They also taught people, especially the boys, how to inject safely, how to do risk management. They became, I don't know if you have the same language in Asia, NSPs, needle exchange programs, so that the boys got safe injecting equipment. They didn't have to reuse needles. They created a safe space for all of this. And the networks of community support. So we have, of course, our own Australian, New Zealand HIV conferences. The little clinic itself took that to the conference. So that's just a quick summary of what the outcomes of that initiative looked like. And it was particularly with a HIV focus. Of the 50 people, I can honestly say all 50 tested negative. 4 years later, they're still testing negative. So we've got young people and older people in this community being happy and connected. The great thing is that little project, of course, was picked up. That city-based services went, let's create the same thing in the city. The country are doing something really right because they're getting great data. So we also now have a city-based sexual health clinic offering trans-specific healthcare. And of course, hormones are the carrot that's dangled in front to get people through the door. The great thing is it is a trans-specific clinic, but the big thing for a lot of the community that I work with is they like their invisibility. So it is in a building that is a general clinic unit. So anyone who walks in is not necessarily going to the trans part. They're going into a health clinic, but there is a trans-specific area. So it is a safe space. So that's another example. I've put in my references the links to the websites for these services so you can have a look at it. But the second part for me was, as I said, stopping our emerging youth becoming the next at-risk vulnerable population. So we work a lot with families to keep families together. And as Nisha has said very solidly, the biggest area is family isolation, ostracized. Again, when I started at the Gender Centre, I left working with young people because I had had enough of them. And I went, I'm going to work for an adult service. And within 6 months, the young people in homelessness walking through our doors surpassed our older population. So it was quite frightening. And most of these young people had come out to their parents, and their parents had thrown them out, not because they were trans, but because they didn't know what to do with them. So we started very solidly a model of family intervention to keep families together. Because if we can do this, then the reality for us is that this is not going to become the next risk population. So to give you an idea of the merit behind what I'm talking about, in the financial year, so June, 1st of July to the 30th of June, one financial year, 137 families walked through our door for support. Again, this is New South Wales only. Remembering we're a small service, we are now talking about one worker seeing 137 families. And the key areas that they've needed: family restoration, transition in school, assistance for families to understand what their child's going through. The number of parents that walked in and said, my kids told me they're trans. What does that mean? And that was the most interesting and most common question. The next one that was really interesting was navigating the healthcare system. We all assume you're sick, you go to the doctor. There are complexities in the healthcare system that as a person not working in the system, you don't realise how hard it actually is, of referrals to specialists, of the need to see a psychologist, the law, or in Australia, if you're under 18, there are certain laws about what medications you can have, what rights you have, what autonomy you have to your body. And parents were at their wits' end with those sorts of things. Children are getting, if everyone knows, the internet is always accurate. So kids are getting on the internet and learning what their rights are. And then they're screaming at mum and dad, I have the right to have surgery at 15, give it to me. And mum and dad were coming in going, what does this mean? We're like, well, no, the internet is never right. It's actually not true. Let's look at the law, and explaining it to children. So we found that if we were keeping these sorts of things happening, and this is what the sexual health clinics are offering families as well in remote and regional areas. So we looked at areas of family counselling, and we looked at family restoration. The interesting one in family restoration was the child that came out to mum and dad very quickly. I'm trans, and mum cries. The child goes, yep, knew it would be bad, and they run out the door. Mum didn't cry because they were trans. Mum cried because she feels bad that she wasn't supporting her child. She didn't see it coming. And the child turns up on our doorstep and says, I'm homeless. And it's like, why? Mum didn't accept me. What did she do? She cried. We ring mum. Mum's still crying, but not because the child's trans, but because the child's missing. And we say, would you like your child back? And she says, yes, please. We do some family restoration work for the child to understand mum didn't cry because she wasn't accepting. Mum cried because she's heard horror stories. She feels like she's a bad parent because she didn't see it coming and support you. So family restoration was a huge thing, and supporting parents, because grief and loss is a very common thing that's not talked about with families. When a child comes out as trans, a parent feels they're losing a son. We work that they're gaining a daughter so that they come through healthy processes. I have to just say, this is my favourite photo. Isn't he beautiful? If we're talking about young people living healthy. He was born a girl, but he's a very proud little boy marching in Mardi Gras. How happy can you be? The other thing that we did was social support, social isolation, peer-led. In those social supports, it's where I learned the really interesting part of life. What do trans people want? They tell me in those groups. If I interview them one-on-one, they'll tell me a bit about their life. As a group and a collective, they have a huge voice. So that was a great one. And the last one was dealing with bureaucracy. We've seen legal transition. We're very fortunate in Australia. You can have a big fat whatever on your passport, irrespective of your surgical or hormonal status, as long as you are living authentically as who you are. You can change your name. But anyone ever dealt with a government department in any country in any world? It drives most parents insane. So supporting families to stay together means giving them the support to navigate the legal systems, to understand the law. And of course, the last part is in early interventions with families, of course, it's working with remote and regional. And this became really important for us, not just the sexual health component, but keeping families together so young people didn't run away to the city, didn't become the stories that we've heard previous speakers talk about of homelessness, engaging in sex work and drug use in major cities. Whole families were prepared to uplift and come into city areas to get the support they needed. They have lived in rural areas their whole life. They're leaving community, families, social supports. That comes with its own problems. So for us, early intervention with families was giving them the support where they are, not bringing it in, not making it harder, not creating more vulnerabilities. And the second part, my third part is, of course, looking at social transition as a focus of mental health. And so we talk, I'll quickly finish because I'm getting the 1 minute mark. The focus for us in working in mental health is talking about being, not passing. We ask the trans community to talk and come up with a logo that is encapsulating mental health. So for us, that's the one that they came up with. It's about being me, not passing to your standards. So we have hundreds of badges, and every year we have what's called Fair Day, which is an LGBTI celebration. Last year I gave out 5,000 of those badges, and I still see them walking down the street. But if we're looking at mental health and support, that is the most important one for us. And so we offer, for anyone that is engaging in hormone therapy, in looking at surgeries, we remind them that that is a three-pronged process, that social transition, living authentically, is the most important part. I'll leave it there. The last few slides you can see, I understand, from a link, and there's references at the end of it that will link you into the documents I've spoken about. Thank you.
Thank you very much, Liz, for sharing the great snapshot, what's going on, what can be done, what have already been done in Australia. I think we are in Asia probably is far behind in terms of addressing on mental health and psychosocial support issues among key populations. And do you have any questions or any reflections? Please come forward to the microphone. Please introduce yourself.
Hi, my name is Nat. I'm a pediatrician at Chulalongkorn University. That was a really inspirational talk. Thank you very much. I have a few comments and also some questions. I think my comments are that I think we're guilty at our department of, so we provide PrEP to transgender women, adolescents. And I think that a lot of them tell us that they've been kicked out of their homes for for their gender. And I think that your talk really made me question about, well, maybe the message they're giving us and maybe what actually happened is a different story, not because anybody intended anything bad, but maybe because of a miscommunication, and maybe there's a lot more that we could do on that side so that the family could be there to support the transgender youth, particularly those who are living with HIV, and it's a little more difficult. And also the work that you're doing in remote areas, I think, is something that we have to think about more, because at the moment, most of the services we're providing is in cities. My question for you is, you talked about helping youth to come to terms with their transition, not just physically, but also mentally. And I think that definitely in my department, we still have not adequately covered this issue. So we provide the hormones. We're not even that good with providing the hormones yet, but we don't really talk a lot about how they can get through their psychological journey. Do you have any pointers for people who are new to this, how we can support them?
There is a really amazing book. I didn't put it in there, and it's a workbook. I can Google it and give you the link. But what it is a handbook for young people in transition. And there are Q&As, and it's literally, so I'm coming out and I'm Alex. So the first question is, what does Alex look like? What does Alex like to do? In 4 years, what will Alex be? What do I like to do? And it's all these questions in social situations. How would Alex behave? So it's those things. How do I tell my parents? How do I introduce myself? How would I like to be addressed? And it formulates a story so that then we work with, and it's not, here's the handbook, go do it. It's actually in a therapeutic context of pick a subject, let's talk about it, and it's in that counselling. So that as you're working with young people to explore identity, one of the interesting things we talk about, and I did make mention I was a psychologist. I did jump ship and become a sociologist in my second degree, and sociology is my passion. And in looking at gender studies, I see someone in transition as actually a migrant in a new culture, because the social roles ascribed to someone when they change gender is so different and so culturally diverse to the one that they have lived in their biology. So it's about learning those. And I say to people, if you were moving to another country, what would you learn? Well, you're moving to another culture. You're becoming a man. What does that look like for you? How do you fit in? How do you challenge those roles? And where do you feel comfortable? So it's a workbook, a series of worksheets, and we do it in a therapeutic context of helping young people to explore. There is no wrong answer to what you look like. It's a right way.
And my last question for you is, you talked about peer support.
Yep.
Can you tell us a bit more about how you train those peers to support, and what sorts of duties they would have to their peers?
Most of our peers are professional people who've put up their hand, who are already working in the sector, who've come back. I have 2 psychologists, a social worker, a nurse, who have all put up their hands to come back. In our young people peer support, we've run workshops where it's like, what do young people need? And some basic peer development stuff. Interestingly enough, one of the most interesting peer workshops we've ever done is cis peers. So someone who is transitioning to male might not feel comfortable asking the doctor, what's it like to go to the men's toilet? What are the social roles ascribed to how men behave? So some of our peers are actually cis people, where you can ask questions of what is it to be a boy in Australian society or in Thai society, or what are your gender roles in a safe space? So trans people know who they are, but sometimes they want to ask of safe allies those questions. So some of our peers are actually cis, where we have binary trans young people wanting to know those values. So
they don't necessarily have to be the same age or the same gender, but just the person who is playing that role. Is that what you're saying?
The best example, I had to step in and run our trans men's group for one night, and I had no idea what to do. So I emailed all the boys going, what do you want? And they went, we'd really love a cis guy we can ask some dumb questions of. So I paged my brother, who the age group for the boys is 18 to 25. My brother was 23 at the time. I brought him in. So he fits in that age range. He was a cis boy, and he became their biggest peer because they were asking questions that were related to his lived experience.
Right. Okay. Thank you so much.
All right. Thank you very much. Please give Liz another round of applause.